We've heard a lot so far about the shortage of primary care physicians generally, and also about different approaches to solving that shortage. And I think the two common themes are there's a couple of different ways to tackle the problem. One is to address the pipeline, address the shortage. And we just heard a lot about that through North Carolina's programs. Another way is to change physicians who are already in the workforce, and how do we change those delivery models to delivery models that can improve access. So the focus of my presentation is really going to be on that second piece. How can we transform existing models of care to improve access and also achieve the triple aim? I'm not going to spend a lot of time on this slide because I think it's really been adequately covered, particularly by those who threw out these figures. But the bottom line is we do have a shortage of physicians, and particularly a shortage of primary care physicians. And we have two alternatives. We can keep doing what we're doing and expect the same results, which, as we all know, is the definition of insanity, or we can change the way we deliver care. We can do something differently that's going to have an impact on access, quality, and affordability. We believe one of the solutions, although it is a multifaceted problem, there's no silver bullet. We believe that one of the solutions is that transformation to that patient-centered care model, a proactive, coordinated care model that Kotz mentioned in her remarks. I would like to step back a second and say, when we talk about a patient-centered care model, we all throw that around like it's a term we use at the dining room table. And I always like to step back and say, what do we mean when we talk about patient-centered primary care, and why do we believe that that's going to have an impact on access? So when we're talking about patient-centered primary care, we're talking about a team-based care model that focuses on support for high-risk patients. So it's not focused just on patients with numbers, or it's not focused on numbers of patients, rather, but patients with numbers. It's a system where there's coordinated care across the delivery system. So you have that coordination, you don't have duplication. You have care plans built around the needs of individual patients. You have facilitated and ensured access, and I'm going to talk in some later slides more about what that means. Importantly, it is a care model, as patient-centered indicates, that's built around shared decision-making and accountability with patients and their caregivers. So patients become an active participant. That active participation alone can help improve access. As people become active participants, they improve their health, they have less need for health care. It's a model that promotes wellness and prevention, and where outcomes and compliance with evidence-based guidelines is measured and monitored. Why do we think this care model can have such a significant impact on access to care, and particularly around that primary care shortage? Well, there's really two reasons. First, it is a move to a team-based care model. And you have that team-based care where everyone is working to the top of their license. So, Kotz talked about in her remarks that, it may be that physicians spend more time, as I've indicated, with those patients with numbers, but that is supplemented by a care team who's working to the top of their licensure and training, who are helping to support those other patients. But also, more importantly, or I should say as importantly, and this really ties into some of the comments that were made by Katie and Kim, it helps make primary care a more attractive specialty. We hear constantly from physicians when we talk with them about the care model and why they like participating in our program. They say it allows them to practice medicine in a way that's consistent with the whole reason they entered into primary care. So you help prime the pump by having programs that like were discussed by Katie and Kim, and then you make it a reality by supporting them to actually deliver care in a patient-centered care model. There are a lot of ways to promote a patient-centered care model, and they were touched upon. In the interest of time, I'm going to focus on two. The four I'll touch upon briefly: payment reform, and again, we heard Kotz talk about that. It's integrated care management, enhanced access, provider transformation, and member engagement. I'm going to focus on these two in the middle for an important reason. First, I think that there's been a lot said about payment reform, and member engagement, honestly, is a subject in and of itself would be a great topic for another seminar, because I think it can have a huge impact on the effectiveness of the system. But the point is that payment reform is really important, but alone it is not enough. And again, if you've heard some consistent themes with the speakers, if you really want to move to these models of care, it requires changes in workflow, process flow, and data. And I'm going to talk about some of the fundamental key changes that need to occur for this model to be effective. And we as payers can do a lot to help promote this model. And again, we can do it through integrated care management, supporting enhanced access, and driving through our programs and resources and tools provider transformation. So what does it mean when I talk about integrated care management? Right now, the traditional model, and it's clearly we're moving away from this, the traditional model of care management has been that physicians are in this fee-for-service treadmill. They're treating patients based on symptoms, and we come in and we do predictive modeling. We identify patients that may benefit from care management and disease management, and we call them, the 1-800 Anthem nurse calls them on the phone and tries to engage them. We believe that there's a better way, that there can be a more interdependent relationship between us and physicians where we leverage each other's strengths, and we help physicians move to that proactive coordinated care model by becoming a more active participant in the care of their patients. And one of the ways we do that is we respect the relationship that they have with the patient, and we no longer, as a result of our predictive modeling, call the patients up and leave that message from that 1-800 nurse. Instead of engaging patients in that way, we actually engage physicians and work with them collaboratively in our care management, allowing them to take on as much or as little as they can in order to be that active participant. It may mean that they engage in care planning, or they do nothing more than talk to patients about the benefit of our model and encourage member engagement. Or it may mean taking on increased accountability for quality and cost by actually leveraging members of their care team for providing real-time care management through resources in their office. The point is for us to use our resources in a way that adds to the resources and assets that the physicians and practices have for the benefits of the patients, and to continue to evolve over time as physicians develop increased capability, so that you might have care management predominantly provided by us today in partnership with physicians, but as we're able to help that transformation, you may be a shift, as illustrated on this slide, to more of those activities provided at the point of care through physicians. Enhanced access is also incredibly important, and we support that in a number of ways. And when we talk about enhanced access does not just mean being available after 9 to 5. It also means alternative methods of access, responding to emails. It means being available for web visits. People work. They can't always get away 9 to 5. And that could be something that's available 9 to 5, or it could be available as a physician extender. So one of the things that we are doing through our tools and resources is enabling physicians to have web visits with patients. We are doing this through Live Health Online, and the concept is very simple. Again, whether it's that patient that has a day job and can't get away 9 to 5, or whether it's that patient that something comes up after business hours. We have a tool where they can get an appointment with their physician through web-enabled technology to help take care of their needs. And the beauty of this tool, it can be a standard office visit with a physician, their primary care physician, that has a relationship with them, Or it can be used to extend, and this is one of the things that we're really excited about as we've met with a lot of physicians who are participating in our program. It can be a tool that's used by members of the care team for care management and coaching, an alternative method of access that doesn't require that face-to-face interaction. Another important aspect of this, as I indicated at the beginning, is that support for provider transformation. And we do this in a variety of ways through information and tools and resources. And what do we mean by that? Well, if we want physicians to engage in a proactive, coordinated care model, we need to give them the information that's critical for them to do so. Most physicians, even physicians that have very active and robust EMRs, electronic medical records today, only have access to information that occur in their four walls. And they don't have information presented in a synthesized way that allows them to focus on the things that they need to focus on and the patients that they need to focus on. So one of the things that we do in our program is we try to simplify the experience for physicians by giving them access to meaningful and actionable information, dashboards with information that help them identify their hotspotters, their patients that have gaps in care, their frequent ER flyers, those people that are going to the ER for avoidable visits, patients who are inpatient in the hospital, that they may not know are in the hospital, so they can get engaged in discharge planning and making sure that they connect with patients post-discharge so that they have the information and resources they need to stay healthy and optimize their health post-discharge. It also means providing access on a longitudinal basis to information that goes on outside their office, and we do that as well. We actually take our claims data and organize it into that longitudinal record. So a physician or a member of their care team can identify a patient on our hotspotter list or on our care opportunity report, that gaps in care, and then can do a deep dive into the longitudinal record that we provide to find more information on that specific patient that can help them manage the patient. It means having access to toolkits, care planning templates, population health registries. These are things that physicians don't get necessarily in training when they go to med school, and it's not intuitive. So providing them with the tools that support population health management, and also offering learning collaboratives. Learning doesn't stop when physicians graduate from med school or go through their residency training programs. Particularly as we talk about these new care models, there's a lot that physicians need to learn in order to, again, change roles and responsibilities in their office, change their processes, change the way they engage members. So we offer learning collaborative. We also offer hands-on associates that can help them understand how they can utilize these new tools and resources and information in their practice to move to that proactive, coordinated care model. One of the things that we're doing that isn't even outside of our physicians who are practicing with us in this care model is we have just launched the American Resident Project, which actually touches upon some of the things in another aspect that Katie and Kim talked about. What the American Resident Project is, it's a series of events planned throughout 2013 that we just kicked off through Twitter and social media at the end of July and the beginning of this month, where we're actually hosting events where we're going to some of the top residency programs, academic medical centers across the country, and are meeting with their residents, family practice, internal medicine, to listen to them, hear what's important to them, and educate them about some of these new care delivery models and some of the things that are going to be important for them to understand as they move into the workforce. So we're actually really, really excited about this and the dialogue that we're going to start by actually meeting with residents and talk to them about new care delivery models. A couple of things that are important, and I'm going to try to wrap up real quickly, is our model is very inclusive, flexible, and extensible. When I say inclusive, we are focused on primary care, but when we say we're focused on primary care, it's focused on those organizations that have a foundation of primary care. It could be a small PCP practice or it could be a large ACO. To us, Um, Organizational structure is less important than capabilities and that foundation of primary care. But it's also very, very flexible because we don't want to regress towards the mean. We want to meet providers where they are, give them the tools and resources they need in a very interdependent, moving away from that transaction-based relationship we have today to a very interdependent relationship tomorrow, but meets them where they are and continues to grow. These are not one and done kinds of programs. We're maturing, they're maturing, and we have to be flexible to continue to grow together. And finally, that gets to the point of extensible, that again, we continue to grow and work with our physicians. The power of one is important, and we focused in my remarks about the Anthem WellPoint models, but we recognize that we're not in a vacuum, and as effective as our models can be, they're more effective when we join together with others, because we know physicians can be more successful when they have all of their patients can be delivered care under these new models. So we are partnering with CMS and the Innovation Center on a variety of initiatives, both as a result of the state innovation model grants that are just starting to percolate, and we're thrilled that so many of our markets have been awarded grants, but also through participation in the Comprehensive Primary Care Initiative in New York, Ohio, and Colorado. So where are we today? We are delighted to say that as we have launched this model of care in collaboration with our participating physicians, today we have 3,600 arrangements in place covering 52 ACOs, more than 22,000 physicians, which includes over 14,000 primary care physicians, and touching nearly 1.8 million of our members. By the end of the year, we believe that 20% of our physicians, whether they're participating in ACOs or small primary care physician groups, will be participating in these collaborative care models that really go towards helping drive that triple aim. And we're going to continue this year to build out the medical neighborhood. Our intent by 2015, 2016 is to have the vast majority of our physicians participating with us in this care model and have to build out the medical neighborhood with complementary programs, bringing in specialists who can work collaboratively with primary care physicians to really achieve, again, that triple aim. And with that, I'm going to turn it back over to our moderator.
Thanks so much, Jill. You teed up the Comprehensive Primary Care Initiative that WellPoint has been involved in, and we're fortunate to be joined now by Dr. Glenn Kotz, who is a practicing primary care physician at MidValley Family Practice in Basalt, Colorado, and his practice has been working with Anthem Blue Cross and Blue Shield of Colorado, and we're really fortunate he could take time out of his busy practice schedule to share some of his experience with us today.
Hi everyone, this is Glenn. I have really appreciated the conversation up to this point, and as we work smaller and smaller through this seminar today, I am giving you the feet on the ground summary of practice transformation. We started our practice transformation about 10 years ago after hearing the initial data on chronic care management in primary care. And that data was showing that our ability to reach evidence-based goals such as hemoglobin A1C management was about 40% of our overall population. And as we started to do our own evaluations, we eventually realized that we did need help in coaching. We spent and continue to spend 5 to 6 years in coaching systems, from Health TeamWorks in Denver to the Colorado Beacon Collaborative to CPCI. This transformation with coaching was invaluable. We never would have been able to do the transformation that we have done without that coaching. As we have moved through this transformation, we have experienced all the positives and negatives that everyone will hear about as far as transformation, from cultural dynamic shifts, cultural burnout, change burnout, to ultimately becoming a continuous learning environment. Some of the things that we learned that I think are invaluable to share are that first, that patient data is critical, population data is critical for us to transform care. It is very easy at some level to be coached to learn how to transform one disease state, to then move to multiple disease states and maintain outcomes above national averages becomes very difficult. We played around with staffing sizes to obtain that, and we're very successful at a staff ratio of about 10 to 1 per FTE provider. Unfortunately, we're unable to maintain that and have seen changes occur with outcomes based on shrinking our FTE size. Another thing that we have found that's very critical is the question of value. I think that we have all been inundated positively with value versus volume care, and that value care is our goal over the next transformation, that we continue to look at value as triple aim value, but we are not necessarily asking the question of what is value towards the patient, and it's a different question. The patients do not necessarily see the value of a lower hemoglobin A1C to maintain diabetes as the state. The individual patients may and frequently see value differently. Relationships, caring, communication are very high on the list. And one of the things that we have started looking at is how we provide value to the patient. And we have started a very intensive program of behavioral management within our practice, trying to add that value to the patient. And we continue to ask that question every day: are we adding value to the patient? We have been extremely successful in engagement of patients. We've been very successful in our staff positive feedback scores, happiness to work in the office. And it's really a wonderful environment for any practice to transform into newer care systems and models. CPCI, being the CMS innovation program currently to help transform us, has been a wonderful model. We are currently working diligently with our local CPCI practices to form a medical neighborhood. And again, as I think everybody on the line is aware of the complexity of coordinated care, medical neighborhood, shared savings, we have the same up and downs as everybody else. I don't want to take too much more time because I know we have question and answers. I'm happy to answer questions as we get into this further. But this is a little bit of our background and our journey. Thank you.